Welcome to the part 2 of the IV-IO lecture summary. Intravenous access is one of the fundamental skills that the paramedic will have. Fluid is used for both blood replacement, administration of medications, and also blood sampling and laboratory analysis. IV access in the field is typically done on peripheral venous access points. This uses veins in the arms and legs and possibly even neck that are outside of the core of the body. And the purpose of access is often determined by how the patient presents and what access you have to them to initiate the IV access. Remember that peripheral veins collapse when the patient is either hypovolemic or hypotensive. They have poor distal circulation, which leads to a diminished venous capacity in the peripheral areas. Central venous access is utilized where peripheral venous access is inadequate, and this is often includes the internal jugular, subclavian, and possibly femoral areas of the body. And central venous access also includes central IV lines, which are placed near the heart for long-term use. These types of catheters are usually just managed by paramedics. They are not initiated. Intravenous fluids are chemically prepared solutions. They replace the body's lost fluids and or aid in the delivery of IV medications. Colloids have osmotic properties that attract water into the circulatory system. Using them in the field is usually not practical. Crystalloids, however, are the primary out-of-hospital solutions. These are electrolytes in water. The solutions can be isotonic, hypertonic, or hypotonic. Lactated Ringer's is an isotonic electrolyte solution. That means it is neutral and does not cause the electrolyte transfer of fluids within the body. Normal saline is also an isotonic solution. 0.9% sodium is the natural sodium concentration in the blood, and 5% dextrose in water is a hypotonic glucose solution. So it would actually draw water from the intercellular space into the vascular space if enough of it was provided to your patient. Remember that you'll occasionally have to warm or cool IV fluid to make it compatible with your patient's needs. Blood is the most desirable fluid for replacement, and whole blood is the desirable form of blood or blood products. Intravenous fluids and blood packaged in soft plastic or vinyl bags in various sizes. Remember, all intravenous fluids are labeled. They all have medication administration ports, and they all have an administration set port within them. Look briefly at the peripheral IV access. Venous access through the external jugular is similar to a extremity peripheral IV. However, the patient should be supine or in the Trendelenburg position. Turn the patient's head to the side and cleanse the site that is exposed. Occlude the venous return by placing a finger on the external jugular just above the clavicle. Point the catheter at the medial third of the clavicle and insert it bevel up at about a 10 to 30 degree angle. The external jugular, while withdrawing the plunger of the attached syringe, will help you gain access. IV bags also come in measured administration sets. Some of them are referred to as Volutrol. Paramedic will occasionally be charged with monitoring or initiating blood in the field, depending on the service that you work in. It's not uncommon to manage a blood during transfers from lower acuity facilities to higher acuity facilities. Blood is mixed with normal saline for administration. The blood chamber itself is actually filtered and has a drip chamber that must be mixed until it covers the filter. The blood tubing must be attached to the IV cannula, or as previously established, IV clamps and or flow regulators should be adjusted the same way as an IV bag flow regulator is for blood administration. There's numerous factors that affect intravenous blood flow. Remember the constricting band. It is not uncommon to forget to release the venous constricting band upon accessing the site. So make sure that you always double check that that has been released. There can be edema at the puncture site, the cannula abutting the vein wall, or a valve can slow or impede the flow of IV fluids. The set of control valves on the administration set, the height and the gravity involved with IV bag placement is significant. And then there is always the need to keep the drip chamber appropriately filled and ensure that the catheter patency is adequate. Sometimes placing a catheter where it can get kinked near a joint can compromise the flow through the catheters, especially on the smaller diameter. Numerous complications are associated with peripheral IVs: pain, possible infection, pyrogenic reaction, allergic reaction, catheter shear, while not uncommon, is a possibility that you must guard against, and inadvertent arterial puncture or circulatory overload from administering too much fluid too fast. There's also the possibility of thrombophlebitis, thrombus formation, air embolism, necrosis around the site, and anticoagulants associated with the clotting factor. Remember, when changing an IV bag or bottle, prepare the new IV solution or bag or bottle first. Occlude the flow of the solution from the depleted bag, remove and spike the depleted bag or bottle into the new IV bag or bottle. Open the roller clamp after you have successfully spiked it and ensure that there's no air involved. IV bolus administration for medication is a common skill that is used by paramedics. This is injecting medications directly into the circulatory system with a concentrated dose of medication through a port established by the IV. Remember to prepare your equipment, check your medication, and ensure your label and your orders match up. Preparing the equipment often involves joining the medication with the syringe that comes in a preloaded syringe, screwing them together, making sure that the dates and the clarity of the medication is normal, cleaning off the ports where you're going to put it, pinching off the tube while you're in it, and making sure that it is done at the appropriate timing and appropriate. Usually you will close off the clamp to the IV infusion bag when you're doing IV bolus medications, as well as pinching off the. Always monitor the patient before and after administration of medication. Remember also, when drawing up a drug and selecting the IV fluids to accommodate that drug, that you choose the appropriate one. IV infusion involves mixing medication into an IV bag. Sometimes this is readily done by the pharmacy. Other times a paramedic may be charged with actually mixing their own medication in the field in case something such as a dopamine or a lidocaine. Remember to clean the medication port on your IV bag. Inject the drug into the fluid, mix it thoroughly, and insert the administration set to connect the main line with the needle and the tubing. Oftentimes we won't run IV fluids. We'll actually put a lock on them. Common locks used in the field include a heparin lock, which is a peripheral IV port that does not have a bag, but has a small injection of heparin, which reduces the clotting at the site of the IV catheter. And these are generally used for longer term, and also saline locks are used for short term, which do the same thing, but they eventually will flush out and could potentially create a clot at the site of the catheter in the vein. Saline or heparin locks are commonly used when fluid is not needed in a patient, but IV access is desirable for possible medication. Patients will occasionally be provided with an indwelling catheter, a venous access device that is placed usually into a deep, large vein. This is for long-term use and generally for medication to be directly injected into a larger vein. These are usually long-term care situations and provide a medication port that is continually available to use by the either patient or clinical providers without continually poking new holes in different veins to administer medication. You should always be cautious when using indwelling catheters. Never access venous access devices unless you have specific needle or techniques for the device. Some of them have specific types of access ports that are only for certain types of adjunct catheters and needle devices. The Huber needle has an opening on its side of its shaft instead of its tip, for example. If venous access devices are not patent or access proves difficult, remember that you should be contacting medical control for advice on how to utilize them if needed. Electrical mechanical infusion devices are designed to precisely deliver fluid and medications through a pump. These include infusion controllers, pumps, and syringe type infusion. This is an example of a syringe type infusion pump where the rate is dictated by the speed in which the pump presses on the plunger of the syringe. This is one of the common ways of administering medication that does not need to be accompanied by a a fluid bolus or within a fluid environment. We also have ultrasound guided intravenous access available to us. These are guided by portable ultrasound devices, which help identify the location of veins which may not be visible to the provider. This is very useful in shock or hypotensive situations or people with fragile small vascular systems. The devices can be used and monitored on a screen to help guide where you would attempt to place an IV. Venous blood sampling is obtained at the time you do venous puncture, during venous peripheral access, and before medication is administered. Venous access for blood draws needs to be coordinated with the labs that will be analyzing the blood that you draw. The color-coded tubes and the way that you do them and the labeling that you do on them is very particular to the labs. They have to know the times, they have to know the sites that it's drawn on, and what the time of day that it is drawn typically. So this is very appropriate for you to be in tune with whatever lab you work with, whatever facilities you transport to, how they would like their blood draws done. Removing an IV is very similar to the reverse process of initiating an IV. However, you must make sure that the flow is off on your IV catheter and occlude the flow with the regulator or the clamp. Remove any securing devices. Sometimes it takes an alcohol wipe if you have very sticky dressings or bandages over it. An alcohol wipe can help remove it from the skin without causing any discomfort to your patient. Grasp the cannula in the HUD and remove it, pulling it straight back at the angle that it is going into the vein. Intraosseous infusion is inserting a needle into a cavity in the long bone or into the sternum. It's most commonly used in the proximal tibia. The insertion site depends on the device being used, the age, and the condition of the patient. The intraosseous needle placement sites depend on the device being used, but most commonly it will be done in the proximal tibial area. It is also done with the drills in the humerus of the adult, but mostly intraosseous injections are done mostly on kids, and the medial tibia is one of the most desirable sites. Equipment is very similar to that for starting a peripheral IV. Getting your needle together, it's a little bit different needle. Usually they are 14 to 18 gauge steel cannulas or drills. This is a picture of an interosseous or bone marrow needle. Often they also, because of the increased resistance in the bone where they go into, they'll be accompanied by a pressure infuser or a bone injection gun. These are the brand names for a few of the IO systems that are in place: bone injection gun, the fast one, and the easy IO. They all have their different ways of applying the needle into the bone. Remember, same process takes place. Select your equipment. Make sure the puncture site is aseptic, and make the puncture, aspirate to confirm proper placement. With IO injection, sometimes you'll have to flush with normal saline, push a few cc's of normal saline into the injection site, and then draw it back to see if it comes back with a pink tinge. Again, appropriate, making sure you apply the puncture into the bone. Usually this takes a gradual push with a twisting motion to make sure it goes into the bone cleanly. It's not uncommon to push too hard, and you can potentially bend the needle. Aspirate to confirm placement and connect the IV tubing once you have it. Make sure the needle gets secured and the site is kept clean. Administer any medications and monitor the patient for the effects of those.
If peripheral vascular access cannot be quickly obtained, the alternative is intraosseous access. For intraosseous insertion, first prepare your equipment. You'll need the intraosseous needle, betadine to clean your patient, a syringe to confirm placement by aspiration of bone marrow, a syringe with saline, and then your necessary IV tubing and extension set, in addition to devices to secure it. In order to inspect the intraosseous needle, you first must know its parts. The external pieces are the needle itself, a flange that prevents you from inserting it too far, and a cap, which covers the stylet. In order to check the needle, take the cap off and remove the stylet. Make sure that it comes out easily and that it can be reinserted easily. Once reinserted, attach the cap again. In some cases, you may want to screw down the flange to prevent insertion of the needle too far. First step is patient preparation. Identify your landmarks. Identify the tibial plateau and tibial tuberosity. You are going to insert 1 to 2 centimeters below the tibial tuberosity on the tibial plateau. Hold the tibia between your thumb and your forefinger. Once you have identified your landmarks, clean it off with betadine using this septic technique. Once the leg is clean, your next step will be insertion of the intraosseous needle. Take the intraosseous needle and remove the cap. First, insert through the skin directly until you've made contact with the bone. Once the needle's been contacted with the bone, use a twisting motion back and forth until a pop is felt and you no longer feel resistance. The needle is now in place and should stand upright without you having to hold it. Remove the cap on the intraosseous needle. Next, remove the stylet. Take your first syringe and attempt to aspirate the bone marrow. If you are able to aspirate bone marrow, the needle is correctly in place. Keep the bone marrow as this may be sent later for samples. Another method to confirm placement is to take a syringe pre-filled with saline, attach it to the needle, and inject. You will feel a slight resistance because there is more resistance through the intraosseous channel, but if the fluid goes in and does not come out on sides of leg or back, then the needle is correctly inserted. Once you have confirmed placement, attach your IV tubing, secure the needle, and infuse fluids as indicated. Because it provides large-bore rapid access, intraosseous technique is now recommended for children of all ages in which you cannot obtain IV access and for which you need this access through an emergent condition. Other than these two, the only other method available is the use of central veins.
Complications associated with interosseous infusion and initiation include fractures, infiltration, growth plate damage, incomplete insertion, pulmonary or air embolisms, possible infections, allergic reactions, thrombophlebitis, circulatory overload. While these are uncommon, it is very incumbent upon you to make sure that you apply proper techniques to mitigate any of these possible complications. Contraindications for IO placement include fractures to the tibia or fibia, osteogenesis imperfecta, which is a congenital bone disease that results in very fragile bones, osteoporosis, or the establishment of a peripheral IV line, which is the priority. Let's discuss a little bit about medical mathematics and drug calculations. In pharmacology, the principal system of measurement is the metric system. There are three fundamental units of measurement, where we use grams as the unit of mass, meters as the unit of distance, and liters as the unit of volume. The metric system is essentially what we would consider a base 10 system. So everything from one grouping to another goes in tenths. So starting with the 0, we usually have like grams would be the unit of measure. And then as we go up from there, we look at decigrams, which is 0.1 grams, or decagrams, which is 10 grams. So when we look at the metric system, we always move in increments of 10 times the previous one. So starting at the top of the table here, kilo would be 1,000 grams, hecto would be 100 grams, deca would be 10 grams, deci would be 0.1 grams, centi would be 1/100th of a gram, milli 1,000th of a gram, and micro is 1/1,000,000th of a gram. Well, you will commonly use the metric system to do all of your drug calculations. One of the most common conversions that you'll have to do is when you start administering drugs proportional to a patient's weight. This is very common with pediatric patients and some adult patients. So converting from the metric system to the English system is one of the skills that you also have to maintain. The weight conversion, when you're given a weight or a drug dose in kilograms, is to multiply it by 2.2 pounds per kilogram. And the thermatic scale, where we have the temperature in degrees Celsius versus the Fahrenheit scale, those things are done in tables because there is no direct multiple number that can be used to convert them. Some medications are also measured in units, which complicates things further. So when we look at the normal units that we use for every day in America, gallon equals 4 quarts, and 4 quarts equals 3.785 liters. So in 1 quart equals a quart equals 0.946 liters, and a pint is half of that. So when we look at the differences in the way that we calibrate measurements, the metric system is an outlier as far as having easy numbers to remember. But if you stay within the metric system and you do all your calculations and your measurements in that, it makes it easier. Converting is only necessary when you don't have accurate information for the equivalent of the metrics. We use medical calculations for oral medications, liquid parenteral medications, IV fluid volumes, and IV medication infusions, where we deliver specific doses over specific times to the patient. Medication administration is a fundamental skill in the treatment of the sick and injured. For medications to be effective, they must be safely delivered to the body by the appropriate route. Specific medications require specific routes for administration, and you must accurately be able to calculate many of the medication doses.